I have to explain the discrepancy between low patency and higher limb salvage rates after revascularization for CLI. Does perfusion matter or not? Sorry. Why is limb salvage higher than patency? So Romiti showed us in 2008 in his paper that between primary patency and limb salvage there can be a gap of 28%. So how does this come? First of all, we have to look, and I think there will be a talk later on, how limb salvage is assessed in this, or patency is assessed in this child. From 2005 to 2015, in 39 studies, patency and limb salvage with at least 1 year follow-up with a minimum of 50 patients in the trials were analyzed. And you see that the assessment was very different, and only the objective assessment of angiogram or angiography was done in only half of the patients in this trial. So sometimes it was a physical examination with IBE or IBE alone, Doppler, duplex. Duplex is, how to say, a good and objective tool, but everybody who is performing duplex scans in below the knee arteries knows how difficult that can be. So limb thread status is determined by the development of a profound degree of ischemia, that's for sure, but limb salvage depends on reversing or managing multiple factors in addition to improving perfusion. It's not only improving perfusion alone. Yes, perfusion matters, I would say, but we should not expect 1 year patency and limb salvage rates to correlate. So even in these dedicated BTK trials, we see that there is a huge gap ranging from 23 to 67% concerning primary patency and limb salvage. Those who have lost patency still potentially keep the limb if reintervention is prompt and successful. So reintervention is one of these tools within this 1 year who might contribute to a higher limb salvage rate and being responsible for this gap of between limb salvage and primary patency. And reintervention at 1 year in these trials I've shown you was ranging from 13 to 50%. And in this Romiti trial, where you have this gap of 28%, also reinterventions have been included to restore patency. The next one, or the next issue is that if you have no tissue loss at the beginning, or a more favorable kind of tissue loss at the beginning, you have a low likelihood of limb loss. So you see, if you have a patient with Rutherford 4 or 5, he comes out better at the end of 12 months concerning major amputation than a patient with Rutherford 6. And this is nicely documented by the Wi-Fi classification, where you see the more severe the wound is, the higher the infection is, or the degree of infection, and the more severe the ischemia is, the higher the risk of amputation. And patients with no wound and no foot infection remain at the low or very low risk for amputation at 1 year. So in these trials, also patients with Rutherford 4 with rest pain have been included. And resolution of rest pain syndrome correlates very well with perfusion. A loss of patency typically presents with recurrent symptoms and rarely immediately threatens the leg. Some included Rutherford 4 patients have diabetic neuropathic pain or ischemic pain, so they might have been reintervened earlier. And the more Rutherford 4 in a study, the less correlation between limb salvage and patency. And therefore you see the gap once again. When you add up the patients in two subgroups where patency and limb salvage should not be expected to correlate, the totals are typically the same as or larger than the gap between patency and limb salvage. What's the issue with bypass surgery? Is bypass surgery better than endovascular for limb salvage? More patients with tissue loss in bypass studies, fewer rest pain patients, and trend towards fewer reinterventions. So we should expect better correlation between primary patency and limb salvage and a smaller gap for bypass than for endovascular. And this is this meta-analysis which shows that you have a lower primary patency for PTA and a higher one for bypass surgery, but concerning the limb salvage, there is no difference between PTA and bypass. There is a gap for endovascular and open bypass, and there is no gap for the different bypass modalities. So my conclusion, limb salvage is higher than primary patency. This is driven by inclusion of patients with no tissue loss and rest pain, re-interventions for limb salvage, and limb salvage should be expected to correlate with patency. The fact that this does not correlate should not decrease the value of perfusion to an ischemic limb. Thank you very much.